maybe it's automatic now. Yes, super. Okay, great. Welcome everyone to the webinar on wasting case detection during COVID-19. I'm very happy to see a good turnout so far. I'm expecting to see more coming as everyone gets connected. First, to introduce myself, my name is Andy Kendall and I am the Tech RRT Program Director. Before we start, I want you to know that there is interpretation available into French and Spanish. If you go down to the button interpretation and choose your language. I can't say that in French, I can't say that in Spanish, but I hope that everyone can find it. A la derecha, abajo, se pueden encontrar un botón para tener el webinar en español y en francés. Geraldine, can you say it in French, please? Or Rita?
Oui, bonjour à tous. Nous avons une option pour ce webinaire pour l'écouter en direct en français. Il vous suffit de cliquer sur la barre en dessous de votre écran sur l'onglet Interprétation et choisir votre langue. Voilà, on vous retrouve à tous. À bientôt.
Thank you, Geraldine. Okay, with that, I want to introduce our webinar today. I don't want to take too much time so that we can actually get to the main reason for everyone being here today, which is to listen to the webinar on wasting case detection during COVID-19. The webinar today brought to you by the Technical Rapid Response Team, also known as Tech RRT, and the SMART initiative, which is part of Action Against Hunger Canada. One of our main presenters today is also from Bazaar, Bangladesh, from the Nutrition Sector Coordination Team. I'm happy to see such a wide turnout today. We have people that I've seen already in the chat box representing across the globe. I haven't seen all continents yet, but I've seen quite a few: Bangladesh, India, Jordan, Uganda, Cameroon, Palestine, Ethiopia, Brazil, Madagascar, Turkey, Nepal, and Senegal, just to name a few. But I think we have many more. So thank you all, and good morning, good afternoon, good evening. If we could go on to the next slide, please. While we are starting to get ready, I do want you to look out down below. In the main bar, you'll see there's a chat box and there's a Q&A section. The chat box, if you could go ahead and introduce yourselves with your name, your organization, and the country that you're calling in from today, that would be great. During the presentation, if you have questions that you would like to ask, please put them in the Q&A button. This will keep the questions in one spot so that when we get to the Q&A at the end, that we'll be able to find them easily. Okay, today's webinar is being recorded, and as I have mentioned, we do have the possibility for interpretation into French and Spanish at the same time. Today is our first day doing it, so please bear with us if we have any hiccups with that. It has been quite a process to get it into place, so many thanks to Rita, who's been behind the scenes to make that a possibility. Okay, so as I mentioned, today's webinar, it is being brought to you by Tech RRT and the SMART team from Action Against Hunger Canada. But we have to acknowledge and thank gratefully our donors, the Tech RRT donors, who are USAID from the team at OFTA, Irish Aid, SIDA, Save the Children, as well as UNICEF. But I need to also mention that this webinar, although is brought to you by and thanks to the support of our donors, the contents of the webinar do not necessarily represent our donors' views. So please do not take their logos here to mean that they endorse anything in the content. Let us go on to the next slide, please. Great. So quickly, just to take care of a little bit of business, I'd like to go through what today's webinar will include. Today, we have first a little bit on the objectives and introductions. Then we have presentations that are the main presentations for today. The first one is on wasting case detection, the key indicators for wasting case detection and their relationship to each other. We have a section that's on the opportunities and challenges of different anthropometric approaches. So what choices can we make and what are the pros and the cons of each? After that, we'll see a way to apply data to different pragmatic approaches. And we're going to have two country examples of this analytical framework, followed by a presentation, a case study brought to you by Bazaar. And then following that, we'll have a panel conversation with Yemen and South Sudan. This way we get to hear a lot from countries to see how they're applying adaptations for wasting programming and in particular around case detection. After that, you have a little bit of information on requesting technical support, followed by questions and answers. And then at the very end, as we wrap up, there will be a webinar evaluation that's trying to get your feedback to see how did we do. Did we meet your expectations? What could we do better? And we ask you to sincerely take the 5 minutes to do it to make these even more useful for you. We greatly appreciate it, and it should open as you leave the webinar. Okay. Next slide, please. Okay, the objectives of today's webinar. Okay, first, it's to discuss the practical realities of detecting child wasting in the context of COVID-19. We know that in the past, there's been lots of possibilities at the health facility level, the community level, as well as at community level, individual level. And during COVID, this has turned our world a little bit upside down, and we need to figure out how do we do it now and what is the best way and how can we make sure that we're finding as many kids with malnutrition as possible to get into our treatment programs. That is the main point of our webinar today. So we will be presenting an analytical framework and a case study to illustrate country level analysis. This will give you some options on how you can make decisions if you haven't already made them, or if you want to see what those decisions actually mean in reality. We also wanted to give an opportunity for country level actors to demonstrate that the adaptations that they have been putting into place. We wanted to provide a platform for actors to ask practical questions in their adapting to the context with COVID-19. We want to be able to help countries make decisions to adapt wasting case detection based on their specific context. One size fits all is not necessarily the answer. Let's look at each country's context to make the best decisions for you. The one thing I do want to note before we go on to the next slide, or before we go on to the presentations, many of you will know that the global level panorama around wasting treatment and wasting case detection can highlight a few different debates that are out there. Today's discussion is not about the technical debate on which methods are better to use for wasting case detection. It's simply trying to look at what options do we have given the context of COVID, and how can we temporarily change our protocols for the time being in relation to wasting case detection. Therefore, while everyone has his or her own opinion on how wasting case detection should be done and what the best way is, today, let's not go there. Let's put all those debates aside to try to help countries to make the best decisions they can to try to treat child wasting. Okay, with that, can we go on to the next slide, please? Okay, so I would like to present today's presenters, and before I hand over to anybody, I'd like to present the people who are behind the scenes. So first, we have Rita. She is our program officer at the Tech RRT and has been a pillar in getting this webinar off the ground, in particular with getting the possibility for simultaneous translation. So thank you so much, Rita. We've also got Geraldine Belloc behind the scenes supporting in the chat box and with anything that's needed at any point during the webinar. And we have 4 different translators who are with us today, 2 for Spanish and 2 for French. We have Ana and Claudia for Spanish. Muchas gracias to the 2 of them for their support. And we also have Christian and Joanne who are translating into French. So thank you very much. Merci beaucoup. Sorry, I'm not going to go into more French or Spanish right now. And with that, so as I mentioned, I'm Andy Kendall. I'm the Program Director for the Technical Rapid Response Team, and we are here today to bring to you some practical help in your programming, and that is our main aim. And I'm going to hand over now to the whole panel that we have today to present themselves. Over to you, Bijoy. And please put on your cameras.
Hi, it's Bijoy Sharkar. I'm working as Smart Regional Advisor for Asia with ACF Canada.
Great, thank you, Bijoy. Over to you, Jose Luis.
Thank you very much. My name is Jose Luis. I'm the current coordinator for epidemiology and public health with Doctors Without Borders in UK and Holland. And it's a pleasure to be here. Thank you very much.
Great, thank you, Jose Luis. Over to you, Alexa.
Thank you. Hello, everyone. My name is Alexa Humphreys. I am the Tech RRT Assessment Advisor based in Lisbon, and I'm handing over to Caroline.
Thank you so much. My name is Caroline Chedo. I work with the nutrition sector. I'm a specialist in Cox's Bazaar. Thank you. Welcome.
Hello, my name is Ismail Kasim from South Sudan. I'm a nutrition manager working with UNICEF in South Sudan and chair of the Nutrition Information Working Group in South Sudan. Thank you.
Hello, my name is Naguib. I'm working as a nutrition specialist for UNICEF in Yemen, and also working on the area of smart survey and assessment nutrition. Thank you.
Hello, everybody. My name is Hassan. I'm the Senior Nutrition Advisor and the Project Manager for the SMART Initiative with Action Against Hunger Canada.
Wonderful, thank you all, and I look forward to our presentations today. With that, on to the next slide, please. Great, okay, so now we get into the heart of our webinar, and I will hand over to Bijoy, please.
Thank you, Andy. So good morning again, good morning, good afternoon, good evening, depending on where you are currently. So I will present, I'll share a few slides on the wasting case detection, key indicators and their relationship. Next slide, please. So as you know, so basically for detection of wasting, we have 3 main indicators: weight for hygiene score, MOAC, and edema as well. And historically, weight for hygiene score has been used in emergency nutrition assessment as well as in other assessment in the development context to assess the acute malnutrition or wasting in children. And assessment like DHAs or MEEKs, they is exclusively rely on weight for hygiene score prevalence to assess the wasting in a population. The mid-upper arm circumference or MOAC innovation was later introduced, which is actually an efficient way to diagnose acute malnutrition among the children 6 to 59 months, and it was also added in the emergency nutrition assessment to provide a standalone prevalence of acute malnutrition. Next slide, please. Okay, so although there were observed differences between weight for height and MOAC in different contexts, but it was often assumed that it has a close relationship. In most countries, as you can see on the graph, this is from one of the study from Liedman et al., that the the median prevalence of weight for height score in most of the countries or continent is higher than the MWAC, and that's why one of the reason of using weight for height score as a caseload calculation or PIN, because it was giving a higher prevalence. Next slide, please. Yes, and also there was another assumption that prevalence of wasting by weight for height score also detect the prevalence of wasting by MWAC. So basically these were two main assumptions that worked behind for mostly using weight for height score as a main indicator for caseload calculation. With the two of these assumptions, one is that it detects also the children with or those who are malnourished by MWAC, and generally because it has a higher prevalence, so countries or organizations, they have been using weight for height score for this calculation. Next slide, please. But we have seen from different research that in most contexts, the relationship between weight for height score and MWAC is not that much aligned that we have been taught before, or you can say it's less aligned. And in many contexts or countries, we see there is actually a very small overlap between weight for height score and MWAC, as we can see in the Venn diagram. Is just an example that in most instances we see that weight for height score it identify most of the children, while a small proportion of children identify by the both indicator, while MWAC only also identifies some children. And this means that to be able to assess either weight for height score or MWAC, will leave a certain proportion of wasting cases undiagnosed. So if we only use one indicator, this means the other portion of the children that identify by either weight for height or MWAC will not be diagnosed. Next slide, please. Well, this slide a bit messy, but we can also share all these studies link in the chat box or through mail later on. So we have studies that support the existing global guidance, and also we have a lot of studies and articles that support the simplified MWAC. So the 2009 joint UNICEF global guidance that was released, it suggests that the recommendation to use weight for height score below -3 score, and for MWAC less than 115 millimeters for the detection and treatment of the children with the severe acute malnutrition. Previously, I think before 2009, the MWAC cutoff was 110, but based on this 2019 guidance, it was suggested to raise 115, and the weight for height it remains same as below -3 score. Well, on the studies that support the existing global guidance to use the both indicator, we have a lot of example here. You can see some example, like in 2016 there was a study. It was from I think 1,832 anthropometric survey from 47 countries, and the conclusion is that weight for height and MWAC are not alternative measures, because these are two standalone indicators and should be used independently to guide admission for treatment. In 2018, there was another study that found that the countries that would fail to identify the majority of some children-related death under MWAC only program, globally, the estimated number of deaths could exceed, if we just choose one indicator, for example, MWAC, would be 300,000 annually. Similarly, we have also a good study that provide example or that provide some evidence on simplified MOAC-only approaches. Like in 2015, there was a study which shows that MOAC and weight gain achieved were strongly correlated. So this portrays the possibility of children undergoing outpatient treatment or OTP to be monitored using MOAC as an alternative to weight gain or to follow up in the center. And there was also study, the combined treatment for SAM and MAM, which was, I think, COMPASS study to standard care, which also look at the simplification of the treatment protocol. So, however, the thing is that
Bijoy?
Yes.
Bijoy, sorry to interrupt. Can you speak slightly closer from the microphone, because some attendees have difficulty to hear you about 3 and 5. So if you can come closer from the mic, thank you.
Can you hear me now?
Yes, I think.
Okay. Yeah. So the thing is that from the operational perspective, we have found the ease of using MOAC, but it's also true that if we just use one indicator, then there will be a quite big number of children will remain undiagnosed or, let's say, untreated because of the because of the omitting another indicator. Next slide, please. Next slide. Yeah, so this is another example from a study in 2019 in DRC, Senegal and Nepal. This was from a pooled analysis of children 6 to 59 months from 3 communities. And this study found that children identified as SAM by MOAC, less than 115 millimeter only, and those who are identified by weight for height Z-score below -3 SD had a similar mortality hazard that was about 4 times that of non-OST children. And when we see the children who are malnourished by both criteria, they had a risk of 8 times higher than the non-OST children. So this demonstrates that both indicators carry a heightened risk of mortality, which increases when children are detected by both criteria. Next slide, please. Next slide. Yeah. Okay. So so the conclusion is that both weight for height Z-score and MOAC are important indicator for wasting. The 2 indicators, they detect frequently cases of wasting in different children, and both are associated with increased mortality risk. So that means if we can include, or when we ensure the use of, or the application of both weight for height and MOAC together with edema. Edema is usually we assess either with weight for height or MOAC. This identify all the children with acute malnutrition in the community. And next time when you read about the prevalence of wasting or acute malnutrition in a report, you may check whether this is prevalence of wasting by weight for height or by MOAC or the combined indicator, or now we call it combined GAMP. Since January 2020, as you know, the SMART and the ANA software, we are providing this combined GAM, which aggregate both weight for height and MOAC together. So this we need to really check like whether this is by weight for height or MOAC. Next slide. So that's the end of my presentation, and over to you, Andy. Thank you.
Thank you so much, Bijoy. I think you set the stage very well to understand a couple of the key indicators that are used in wasting case detection. Thanks a lot. Now we are going to go over to opportunities and challenges of different anthropometric approaches. And Jose Luis from MSF UK will be leading us through this part of the webinar. over to you, Jose Luis.
Thank you very much, and thank you for that introduction and summary of this complex issue of MUAC and West for Height. I just wanted to mention what Andy explained at the beginning. I want to take now a step further and look at opportunities and challenges of these different anthropometric approaches, but within the current situation that we are living now within COVID, and what challenges both of these type of measurements face in the time of COVID. I see there are a lot of questions about, or some questions already more general about MUAC versus Wave for Height, but we're going to try to focus on challenges and opportunities during COVID. Next slide, please. As you know, as most of you know, COVID has changed well, not only the acute malnutrition, not only the nutrition sector, not only even the health sector. I mean, a few months before COVID started, I was traveling to the field. I was implementing a nutrition survey in Angola. I was supervising CMAM projects in South Sudan and Somalia, and now I've been 6 weeks sitting at my desk at my house. So this is changing for everyone, and programs in the field also are adapting in different ways. I think also Andy mentioned at the beginning that there is not one protocol, there is not one approach that all the countries, all the programs, all the organizations are following, but they are trying to adapt to what they find is more practical in the different contexts. So what I'm going to do now is to summarize a little bit what we are seeing in the case detection of acute malnutrition. As you can imagine, the implications and the changes that happen at case detection of acute malnourished children, and also for diagnosis, then they have more important implications for admission, even for treatment and for discharge. But I believe that those we will discuss more in detail in other webinars. And now we're going to focus how these nutrition programs are adapting on the case detection of wasted children. Before COVID, case detection was an important part of CMAM. This is because one of the main challenges of CMAM is that it's not reaching enough children. As you know, coverage of CMAM programs is not good enough, and we are all trying to increase coverage of CMAM programs around the world. CMAM programs are very effective, but coverage is one of the main issues. And when we analyze barriers to access to CMAM programs, one of the main things that we often see is that people don't know that the children are malnourished, people don't understand about nutrition, people don't know about nutrition programs. So before COVID, case detection and screening were encouraged at all levels, at health facility level, at community level, and at household level. We were doing this via active screenings and passive screening. As you know, the difference is that active screenings, we are going, for example, into the community to measure everyone, or in a health facility, we are measuring everyone that comes into our health facility, no matter what the reason for them to come to the health facility. What passive screenings refers often to people who come to a consultation for other reasons, and you take the opportunity of diagnose and explore acute malnutrition. So we were doing this at all levels that we could, active and passive health screenings. The reason why being double, one, as it says there, because sensitivity of wasting case detection improves when both active and passive screening is done. But the main reason was because we need to try to detect more cases, because that's the only way that we are going to increase coverage of treatment of acute malnutrition. Now COVID has happened, and physical contact between non-host members is avoided. So what many countries are doing is to move for a more centralized case detection activities to a more decentralized case detection activities. But using here the word centralized to explain the rationale of moving from a health facility level where people need to concentrate, where people are more at risk of contracting COVID, to community level where we have community health workers and delivering and doing the treatment, to a household level where there is the own caregivers, the ones that are participating in the case detection of acute malnutrition, of acute malnourished children. Within each one of these levels, you can also see different levels of centralization and decentralization. For example, a health facility level, we can talk of very centralized big hospitals or very outreach health posts. And we are again moving even within that level from a very decentralized to a more decentralized. At community level, again, we can see more decentralization happening from people gathering in the main square of a village to going more door-to-door activities. So at even a household level, probably we can see more decentralization happening these days with big households sharing many things, with now households splitting into smaller groups. So this decentralization process is happening at all levels. Thank you very much. Next slide. And the main reason of this decentralization is to avoid people congregating at a specific site. So case detection is already changing during COVID. It's moving, it's decentralizing, and this is having a huge impact on the way we are performing it, especially because at health at community level, now the new IPC, infection prevention and control measures apply. So people need to, for example, in Doctors Without Borders, we haven't stopped our community level activities, but now we recommend that our community health workers don't go into the households of beneficiaries, and that they are wearing a face mask at all times, etc., etc. So the requirement of protection equipment is quite encouraged at health and community level. Same thing, we need to disinfect anthropometric equipment every time we use it. Physical distance is very important. So all these things have put some challenges into case detection. Sometimes it can be done, but it also requires more resources and more time. At household levels, normally we don't require personal protective equipment because the caregiver is sharing that space with their children at all time. So there is no need to put a face mask for diagnosing. Doesn't require disinfecting anthropometric equipment. I mean, especially if you have one child only, there is no reason for that. In some circumstances, it's recommended, of course. There is no need for distancing measures at household level, but sorry, my phone was ringing. But the problem at household level is that it's more difficult to ensure quality, and people and caregivers at household level remain largely untrained as compared to those at the health at community level. I just wanted to remind us here that community level includes also door-to-door activities. Household level, we are using it in this webinar to reflect caregivers doing case detection on their own household without external participation. While community health workers going household to household, we are including that at community level. Thank you. Next slide. So as I was saying at the beginning, there are different approaches. We have tried to group them here into 6 main groups, more than 6 groups. What we see normally is a wide spectrum and every program adapting to different levels. But we have, for the purposes of learning and knowledge sharing, we have grouped them here in 6 groups. The 6 groups that I'm going to explain very quickly today is the first one is the business as usual, using both weight for height, MUAC, and edema to detect wasting. The second one is using only MUAC, but only for SAM detection. The third one is again using only MUAC, but here for SAM and MAM detection. It's what we often call the simplified or combined approach. Number 4 is again MUAC only, but here expanding our cutoffs. So it's not going to be 115 for SAM, but probably higher, 116, 117, 118, and it's not going to be 125 for MAM, but it's going to be 130 or 135. And group number 5 is, in addition to MUAC, adding weight for age for waste detection. And number 6 is all this 3D anthropometric body scanning that we've heard a lot about it. We are not at a stage where we can use them in the field, but we would like to mention them here because we think they're going to receive a huge push during this COVID time. So next slide, please. I'm going to discuss now some very practical opportunities and challenges for each one of the 6 approaches. But as you can see, there is a lot of information there. At the end of the webinar, we are going to share a more comprehensive document outlining opportunities and challenges to each one of these approaches, where you can see all the opportunities and challenges much more well detailed. Going to the first approach, using both weight for height and MUAC, and of course edema. Every time edema is there, but we're focusing on the anthropometric ones today. The main challenge here is that in order to measure weight and height, the child needs to be in close physical contact with the healthcare workers. And for height, you need 2 health workers. So that's one more probability of contracting COVID. The risk of contracting COVID during this measurement is small, and it can be minimized a lot with distancing, hand washing, IPC measurements, etc. But nevertheless, is there. So the big challenge during COVID times is exactly that. And the second big challenge is that the access to health facilities. Many family members might have fear or rejection to go to health facilities, so may not go to health facilities to receive normal health care as before COVID times. Obviously, this approach is not implemented at household level, since weight and height boards are normally not available at household levels, and only MUAC is available at household levels. At community level, this approach has been implemented in the past and is still implemented now. However, the challenge, the limited availability of height boards and weight scales, or the limited availability of time and resources at community level, has made in the past that not all community activities include measuring of weight and height. Next slide, please. So this is why some programs have changed to a MUAC-only approach. And for example, when COVID started a few months ago, 2 countries, Nigeria and Chad, decided, okay, let's focus on MUAC and let's focus only on some children. The advantage of this is, of course, there is less contact with the healthcare workers, so there is less risk on contracting COVID, and also we are not measuring MAM, so that's reduced. The main challenges here is, as my colleague just explained now, that MUAC and weight for height don't measure the same children. So we are missing all those children that before were identified by weight for height, because now we are not measuring weight for height, and the children that were identified with MUAC only may not be the same that would have been identified by weight for height. And second, with this approach, like the ones they implemented in Chad and Nigeria, that MAM cases are being missed since we are only focusing on some children. The good thing is that it can be implemented at a household level because families have MUAC tapes and they can implement MUAC and edema at that level. Next slide. The next approach is approach number 3. Is similar to number 1, but now it's like, yes, we can use MUAC only, but we can use MUAC only for measure both SAM and MAM. And this was at the beginning of the simplified and combined protocols that have been piloted for the past, I believe, 4 or 5 years now, that include also more than just case detection. They also go beyond case detection into treatment and discharge criteria. Today we are focusing only, as I said at the beginning, on case detection for acute malnourished children. So in these simplified approaches, we are using only MUAC, also edema, but as an anthropometric criteria, we are also only using MUAC. That way, we are avoiding all those challenges at health facility level with measuring weight and height. But again, the problem is, as before, the poor concordance between MUAC and weight for height. So we are still missing all those children that will be positive for weight for height, but negative for MUAC. Thank you. Next slide. The FOR approach, again, is a MUAC-only program, but in order to reduce the amount of people that we are missing and that would be wait for height positive but MUAC negative, we are increasing the thresholds. So instead of instead of 115 for some, for example, we are using 116, 117, 118 as a threshold. That way we're including some children that are not positive according to the case definition of the World Health Organization. For example, a child that is 116, but we that child, maybe we're capturing some children that are weight for height positive, but with a MUAC of 116. This has been implemented in the past in many places, but not nationally. For example, MSF programs in Burkina Faso it's been already 3 or 4 years where we've been implementing similar approaches. Next slide. The other,
we've got
yes.
2 minutes.
Yes.
2 minutes, thanks.
Thank you. The next is in order to increase, again, the testing capacity of MUAC to add, for example, other anthropometric indicator, weight for age. The idea of adding weight for age is to not adding weight for height, because that way we age measuring height, which, as we know, has some special challenges, like the need for a second enumerator. So with weight for age, we could, again, increase the testing capacity of MUAC without adding the measurement of height. Again, the problem here is that we may get some children that are positives, but according to the WHO definition, using weight for height, MUAC and edema, they will be negative. So we might increase, we are increasing the testing capacity, but we may introduce some false positives, meaning some children that maybe the MUAC is 117, the weight for height is inferior to -3, and the weight for height is more than -2. That way, according to WHO classification, there will not be a SAM case, but according to our new definition, by introducing weight for age, they will be positive. So these are some false positives. Next slide, and our final approach, as I was saying, was these new techniques of 3D body scanning technologies, the SAM photo diagnosis, using mobile phones and cameras in order to detect anthropometry and to identify a child as acute malnourished or not. Of course, here many opportunities. We avoid direct contact even because we can't even maintain a physical distance. Main challenge, we are not ready yet. These technologies still require a lot of field testing, and we are still in a very early piloting test in most of these. Next slide. Just as conclusion, the final message I was going to say that these 6 approaches at different levels at what we can do at health facility, community, and household level. In the context of COVID, we are seeing already a huge increase towards, for example, what we call family MUAC, case detection at the household level. I think this is something that is happening, if not all countries, most countries. So there is this huge movement towards that, and we want to support that movement. And some programs have already transitioned to MUAC-only approaches. Officially, most countries continue to use both weight for height and MUAC in their national protocols. But as I said, when we talk about a specific context, we are seeing different scales, different adaptations, and some of them, most of them, are transitioning to a MUAC-only approaches for case detection. Of course, always ensuring reinforced IPC measures. Thank you very much, Andy.
Thank you so much, Jose Luis. I think you did a great job of demonstrating some of the different ways that we can detect wasting and the pros and cons of those. Thanks a lot. We are a bit behind now, not because of Jose Luis, but just in general. So I don't want to take too much time to hand over to Alexa for our next presentation on applying data to different approaches. So in this, she's going to show us how you can use data to make some decisions to see what you think is the most appropriate for your country. Over to you, Alexa.
Thank you, Andy. Now, first of all, thank you, Jose Luis, for that very practical overview of some of the opportunities and challenges with using different approaches for case detection. Now we're going to switch gears a little bit. we're going to ask some similar questions, but we're going to ask about what are the capabilities of these different approaches when we apply data to them. Next slide, please. Thank you. Now, this is the exact same table that we saw earlier in the beginning of Jose Luis's presentation. It outlines the 6 different approaches that we're discussing during this webinar. And in terms of applying data to them, I'm not going to take us through this process of applying data for the first approach, because we are working from the assumption that where every child is where it's possible to screen every child using weight for height and MUAC, most true cases of wasting will be detected. However, we can use data and apply it to approaches 2, 3, 4, and 5 to help understand the capabilities of these approaches for the given context. Approach 6, we're also not examining with data because this is something that's currently being developed, so we're not analyzing it today. Next slide, please. Now, before we jump into the results of the analysis that I am going to present, I want to clarify one important concept for this exercise. We are going to be applying population representative data, so assessments and surveys, to these approaches. During my presentation, we are not going to look at programming data, which I know it's a bit of a departure from what we normally do, but keep in mind, this is all assessment data. The reason for this is, the reason we're going to use assessment data to look at these approaches is because although programming data can help us identify incidents of acute malnutrition, it can help us monitor trends, and it can help us understand the characteristics of the children that are enrolled in programming, so we can look at age, sex, and their nutrition status. It doesn't help us understand children who were never detected as wasted, and they never entered into a treatment program. However, because population representative assessment or survey data provide a snapshot of the population of children under 5 for a given area, we can actually use that data and apply it to these different approaches and estimate how the approaches may perform for a given population. Next slide, please. Okay, let me show you what I mean. We're going to go through a quick thought experiment. So let's imagine for a given area, an imaginary area, we're going to apply MUAC only less than 115, and 350 children are detected. All would be wasted by WHA global thresholds because they're all SAM by MUAC less than 115. And that's that first column, that first orange box. But what it wouldn't tell us is what proportion of SAM cases were left undetected. In this case, by weight for height only. Children that were only SAM by weight for height. And that's that little invisible box with the dotted line around it. How can we begin to estimate what cases we didn't see? Now, let's say for this thought experiment that we wanted to raise our threshold, our MUAC threshold, to 133 millimeters. And let's say for this thought experiment, we then detected 400 other children that fell under that threshold. It's that lavender part of the second column. Our question about these children is naturally going to be, what is the composition of these additional 400 children? Are they true SAM cases by WHO thresholds? Are they MAM cases? Are they false positive? Well, what we're going to try to do is to use representative data to help anticipate what those additional children could be. Next slide, please. So now we're going to go beyond that thought experiment, and we're going to look at 2 different countries utilizing their data. They have been anonymized because we don't want to get into the details of the countries themselves, but we're going to start with country 1 here. And I'm first going to there's a lot happening on this slide, so I want to familiarize you with the slide first. The first thing we want to examine is along the bottom of the graph, the different approaches we're looking at. So we're going to be looking at approach number 2, which is MUAC only less than 115. We're going to be looking at approach number 3, and which is MUAC only less than 125. And then we're going to look at, because approach 4, as we framed it for this webinar, is could be based on various cutoffs. But for this example, we're going to use less than 130 and less than 135 as examples. And then for approach number 5, we're looking at weight for age z-score less than -3, as well as MUAC less than 125. Now, before we start examining the content of the columns, let's note the circular images along the top of the graph. Each of these circular images is looking for each approach. How many of these children are truly wasted, they're SAM or MAM, and what proportion, the truly wasted are that yellow-orange color, and what proportion are what we call false positives. They're not malnourished by any WHO indicator. Their weight for height z-score is greater than -2, and their MUAC is greater than 125. So that's in green in those circular graphs. So for example, if we're looking at approach number 2, that is MUAC less than 115, we can see that all true SAM cases, we're predicting that about 25.7%, or 1 in 4 true SAM cases, would be detected using approach number 2. And 74.3% of SAM cases would be excluded. No MAM cases would be detected using this approach, because that's not the objective of this approach. But also you're going to have no false positives. All these children are true SAM cases. Now for approach number 3, based on our estimates, we can predict that a MUAC threshold of less than 125 could detect 63.3% of true SAM cases, with 36.7% excluded. And this approach for this country we're examining would detect about 29.3% of true MAM cases, while excluding 70.7% of them. But still for this approach, there's no false positives included. All of the detected cases are either truly SAM or truly MAM. Now, if we step back and we apply this logic to all 5 examples, we can estimate that having a MUAC threshold raised to less than 135 millimeters has the capacity to capture the largest percentage of true SAM and MAM cases. But this could also include the largest proportion of false positives. In this case, 40.3% of all the children referred would be false positives. They would not be malnourished by global thresholds. This brings us to the question, what is the trade-off between detecting more wasting cases and also having more false positives included, whether that is for screening purposes or for treatment purposes? Still looking at country 1, the approach that would detect the next largest population of true wasting cases is actually approach number 5. With 88.1% of the SAM cases detected and 58.4% of the MAM cases detected. And yet it has a lower proportion of false positives, it's 18.8%. A note of caution in general on this though, this is, the point of this is not to be prescriptive and to say that this approach should be used or this approach should be used. There's a trade-off, it's something to be considered. And also a note of caution that this relationship between weight for height and MUAC, as mentioned previously, really varies between countries. So it's an exercise to do country by country. Next slide, please. Now here we're looking at the anonymous country number 2, using real data. We're looking at the same approaches and it's structured in the same way. In this example, we see that MUAC less than 115 is capable of detecting a relatively large proportion of true SAM cases. In this case, 79.2%, or more than 3 in 4 true SAM cases would be captured with a MUAC threshold of less than 115. This is much higher than we observed in country 1. In country 1, it was just 1 in 4 true SAM cases that could be detected. In the case of country 2, there seems to be a much higher concordance, higher alignment with weight for height and MUAC. which is allowing us to capture more wasting cases. Meanwhile, among the other approaches in this graph, the highest proportion of true SAM cases, 94.2%, would be detected usually using weight for age less than 3 and MUAC less than 125. However, by using a threshold of MUAC less than 135, the highest proportion of MAM cases would actually be detected, 89.4%. However, we also need to note that there is a very high proportion of false positives with this approach. We can see that for approach number 4, and we're calling it 4B here, it's 64.8% of all children that would fall under that threshold that are actually false positives. Next slide, please. Okay, thank you all for being a part of my very data-driven presentation on applying population representative data to different case detection approaches for different country contexts. Together, we examined how applying this data can help us, predict the proportion of true wasting cases that can be detected using different approaches, and also detect the proportion that could be excluded. My key takeaway for everyone from this is just to re-emphasize the importance of utilizing the data that you have for your country or your region or your program area to help support decision-making when you're choosing your approach. Thank you.
Super, Alexa. Thank you so much for your presentation. It gives a really good demonstration of how, if we apply data, we can look to see how to balance the idea of increasing cut points and how we're going to catch the most cases while also trying to not have too many false positives, because we know that has an effect on our pipelines and supplies, and we need to make sure that we can meet those demands that we're going to have. With that, we are a bit behind. I just want to mention, I do see lots of questions coming into the chat box. If you have questions, can you please be sure to put them in the Q&A channel? That way they can be addressed during the questions and answer session later. For now, we are going to go on to our case study from Cox's Bazaar, and I'm going to hand over to Caroline. In this case, we're going to get to see how they have actually applied their data to a specific country. Over to you, Caroline.
Thank you, Andy, and thank you, Alexa, because your presentation is just in line with what I'm going to present right now. So for the Cox's Bazaar case study, yeah, so we are just next slide. So I just want to thank also the technical rapid response team for helping us in analyzing this data, and also SCF Canada. And I also want to recognize also SCF who have been the technical lead in terms of taking assessments in Cox's Bazaar. So just to give a brief background of our nutrition programs in Cox's Bazaar, we know, we have read this, that violence in Rakhine state of Myanmar erupted in around August 2017, driving more than 700,000 Rohingya men, women, and children across the border. And with this, all these populations, they have been depending entirely on the humanitarian support, and so far they have increased in number. We have more than 800,000, and you could see more than half of them are children and 49% of them are adults. So in the Rohingya response, we have 3 major camps, and if I can just mention by name, we have a makeshift settlement, we have Kutapalong, and we have Nepara registered camps. These are 3 mega camps hosting a total population of more than 860,000 persons. And nutrition programs have been established in like 45 nutrition centers in different localities within the camp. And so far we've been operating in those nutrition facilities. So looking at the nutrition situation over time, we've seen a really an improvement in terms of nutrition situation. From August 2017, the GAM levels were at 21%, and currently we are talking about 12.2%. So we've seen at least an improvement over time, but still we'll say that the status still remain unacceptably high. On this other side, on the right side, I'll just show the relationship about the weight for height and the MUAC in Cox's Bazaar, and we've seen that there's poor concordance, and it's just displayed in the different colors. We have the yellow color and the light green color and the blue color, that in Cox's Bazar, we are using both indicators in the detection of malnutrition cases, in that if we only go by, let's say, MWAC only, it means that we'll have so many cases going on and undetected. So in Cox's Bazar, we do apply both Z-score and MWAC, given the poor concordance and the poor relationship between the weight for height and MWAC. Please proceed. Next slide, please. So in this slide, now I'll be talking about the scenarios. Over time, since the beginning of the response, we've had like different scenarios in terms of like the referral cutoff point at the community level. And I will display it in 3 different colors. That is the gray, the orange color, and the light green color. You know, yeah, the colors might not be the way you are looking at them at the moment, but just basically the key information here is that we had different scenarios over time. And the scenario 1 is when we started our response, the MWAC referral cutoff point at the community level was less than 12.5, and that was until July 2018. As quick survey was conducted, assessment was conducted, and we realized that the OTP, the TSFP coverage was very low. So with that, we decided that we needed to increase our referral cutoff point to 13.5, and that brings us to scenario 2, where now the referral cutoff point is 13.5 until around April 2020 this year. From there, then again, we move to scenario 3, where the MWAC referral cutoff point remains at 13.5, but then again, of interest is our admission protocols. So scenario 1 and 2, the admission protocols are as per the global standards. That is for the different programs, the OTP, that is the outpatient therapeutic program, the stabilization centers, and the therapeutic, targeted supplementary feeding programs. They remain as per the global standards. But of interest is scenario 3, where we had to adapt MWAC only for admission, follow-up, and discharges. So we have our outpatient therapeutic program admissions for all cases with MWAC less than 12.0 centimeters and presence of edema. And we're looking at the targeted supplementary feeding program with MWAC range of 12.0 centimeters to less than 13.5. So this is being implemented right now until, from April 2020 until to date. Next slide. So I'll just take you through the admission trend over time since beginning of response in August 2017 to around April, June 2020. And we will see that there are so many fluctuations over time. In terms of admissions, we'll also display it in different color codes, looking at the red color depicting the OTP and the AC admission, and the yellow color depicting the MAM admissions in the TSFP programs, and also in relation to the scenarios that I've just spoke about. So looking at the admission, we have the spikes, and more so with Cox's Bazar, it's really a unique locality, with sometimes the monsoon period, which brings in a lot of morbidity cases like acute respiratory infections, diarrhea, and we see a spike in terms of admissions, like maybe looking at the month of July, looking at the month of also January, and then also looking at different seasonalities take place in terms of the admissions, play a role in terms of the admissions. And I would say that admissions have fluctuated over time, with some admissions following a downward trend and MAM admissions appearing to increase in relation to some admissions. But of interest is if you look at scenario 3, we've seen that there's a spike in admissions, and this is more so related to the admission criteria that we are applying right now. And also in January, we also saw a very high spike in admissions, given that we had a real shift. Initially, we had fragmented service provision, but right now we are talking about integrated nutrition services, and this saw a lot of reshuffling and thereby giving us a high number of cases in terms of admissions in the different programs. So below, looking at the blue color code, moving forward in the next key slides, I have the blue color code. I don't know whether it is visible to the participants, but the blue color code is just to clarify the different scenarios that I've spoken about. Scenario 1 and 2, following the referral cutoff and also following the global cutoff for admission criteria in the different programs. scenario 3 being a unique case with adaptations based on the COVID-19 situation. Next slide. So previously, in the previous slides, we've looked at the program admission data, but now we want to shift to applying survey data to the 3 scenarios that I've explained. And we'll be using the population representative data from the SMART surveys that have been conducted in Cox's Bazar. So far, we have conducted 10 surveys in a period between 2017 to 2019 in the 3 registered camps. So when you look at Kutapalong, we've done 2 surveys. Each camp is just taken uniquely, where we conduct 1 survey per camp. We have Narapara registered camp, where we've done at least 4 surveys, and the makeshift settlement, where we've done 4 surveys between the period 2017 to 2019. So with all these surveys that we've done, we have a pooled analysis of about 4,731 children, 59 months, was conducted just to understand the relationship between the weight for height and MWAC in Cox's Bazar for the 3 case scenarios that I've already mentioned before. Okay, let's move on, please. So remember that now we have shifted from our program data to survey data, and now we have different scenarios, scenario 1, 2, and 3. And looking at the different color codes, we have different color codes. We have the red color depicting like all SAM cases detected, and looking at the yellow color depicting MAM cases. And these are cases that have been found to be malnourished based on the 2 criteria, that is MWAC and the weight for height. And then we have the gray color depicting the exclusion, the number of cases that were excluded. So looking at scenario 1, when our cutoff point was 12.5, we could see that we were only able to detect 58.7% in terms of SAM, and in terms of MAM, we were only able to detect 27.7% with an exclusion of about 72.3%. But then again, if you compare now with scenario 1 and scenario 2 and 3, we see that we had a positive gain from 58.7% of this all SAM detected in scenario 1, we were able to increase the number of cases to 89.0% in scenario 2 and scenario 3, with at least minimal exclusion. And also the same goes to MAM, where we were able to detect 27.7% of cases to 66.1%. So we'll say that this was a positive gain when we raised our referral cutoff from 12.5 to 13.5. Thank you. Next slide. On the same note, we'll be looking at the admission capability for the scenario, like all the detected cases. What is the admission eligibility among the detected wasting cases, like in scenario 1, 2, and 3. And then again here, we have the different color codes indicating the green color for all the SAM cases treated, the gray color still remaining as the exclusions, and then the lighter green indicating the MAM cases. So in scenario 1 and 2, we see that all the cases were appropriately admitted into either OTP or TSFP based on their true status, because they were both verified by weight for height and MWAC at the health facility level. We had no false cases. Yeah, so I'll talk about the false positive in a short while. So looking at that, at least we can see that in scenario 3 of interest will be like scenario 3, because now admissions are based uniquely on MWAC. Like I've already mentioned, the MWAC is the only, we only adapted MWAC for admissions, follow-up, and discharges. And we could see that we have a 5.9% of cases that were treated as SAM. So scenario 1 and 2, at least all the cases were true SAM or MAM cases, and they were admitted into the program. But now when it comes to scenario 3, it gives us a challenge that we have 53.2% of the cases who should be treated in the, all the SAM, 53.2% of SAM are treated as MAM. And also looking at the MAM program, we have 5.9% of cases in MAM program treated as SAM. So that is one of the challenges that we have noted in terms of, and we'll talk about some of the challenges as we move on. Next slide. Yes, now we'll talk about the false positive in this case. And another challenge that we've noted, that previously we've seen that we have misclassification in the previous slide, but another challenge that we noted is false positive. And in this case, we'll define a false positive as a child who is not wasted by any global thresholds. So in scenario 1, at least all the cases who were referred were truly wasted. But in scenario 2 and 3, we have different scenario. And also this is depicted in different color codes, where we have the blue color as the false positive sent home and the green color as false positive treated. And the yellow cases indicative of all the true SAM or MAM case. Now in scenario 1, at least all the cases that were referred were admitted into the program. And we are looking at scenario 2, whereby we had 48.7% of cases were wasted based on both ZISCO, wait for height, MOAC, or REDEEMER. But then again, the challenge comes in terms of the false positive. But in Cox Bazaar, it's just good to mention here that at least all these false positive, they were not sent home. We admit them in the blanket supplementary feeding program. So at least we are able to deal with the issues of rejection in this case. But of interest, it is good to note that in scenario 3, of all the cases that were referred, 48% of them were true SAM or MAM cases, but we had a 51.3% of cases who are false positive, but they are treated into the program. So, but looking at this, despite the challenge, one gain that we can be able to notice that both scenario 2 and 3, we had a number of increased children referred was more than fourfold. So that is a positive gain, despite the challenge that we have almost 51.3% of cases being treated as false positive in scenario 3. But then again, scenario 2, these cases are sent home, could be sent home maybe in other programs, but in Cox Bazaar, we have the blanket supplementary feeding program where they are being admitted. Next slide. So looking at the last 3 slides, we've talked about how we've seen how the raised MOAC referral threshold could help us in on detecting more SAM and MAM cases. And also we've looked at the 3 scenarios, what it meant in terms of program eligibility and the challenge of additional false positive. So the 3 previous slides. So in this case, now we look at all the overall cases. We'll look at the 3 scenarios in terms of all the overall wasting cases, that is SAM and MAM, and what proportion of wasting cases are correctly classified, treated, misclassified, or excluded. And this also has been illustrated in 3 different color codes. And looking at the 3 color codes, we have the gray color indicating the exclusions and the green color indicating correctly classified and treated. And we have a small orange color indicative of misclassified. So in scenario 1, we see that 32.2% of the cases, wasting cases, were correctly identified and treated, but we had a 67.8% exclusion. In scenario 2, we see that the number of cases that were correctly identified and treated increased by almost 50%, 69.4% were correctly classified and treated, and we had an exclusion of 30.6%. We didn't have any misclassification. But in scenario 3 now of interest is scenario 3. Remember that the admission criteria for scenario 3 has changed. Scenario 1 and 2 focuses on the global thresholds for admissions in the different programs. And scenario 3 now, it is more of MOAC adaptation. And we see that out of the cases that were referred, 56.7 were correctly classified and treated, But then again, we have a 12.7% number of proportion of cases that are misclassified and a 30.6% of the cases excluded. So scenario 2 and 3 is almost similar, but the difference comes in when it comes to the misclassification in scenario 3. Thank you. Let's move on. Next slide.
Caroline, we need to start wrapping up, okay?
Thank you, yes. In scenario 3, now we are looking at, we'll be looking at the allocation of OTP and the Stabilization Center, the TSFP programs, considering the true status of children eligible for admission in the different programs. That is just in scenario 3 criteria, where we have adapted MOAC criteria for follow-up, admission, and admission, follow-up, and discharges. So until now, we've looked at the previous slides, we've looked at the opportunities and the challenges of raised MOAC referral threshold for Cox's Bazar, and we've seen the estimated implications for true wasting cases. Now, at this point, we're going to estimate the composition of enrollment, how it would look like, looking at specifically scenario 3. For scenario 3, looking at now the OTP and the AC, we will estimate that at least the enrollment in the OTP AC will be composed of roughly half true MAM cases and roughly half true SAM cases as depicted in the figure 1, when we're looking at 49.4% MAM treated as SAM and also 50.6% of SAM all treated. So this is the true value cases of MAM who were treated, but then again we had a 49.4% MAM cases who were treated as SAM. In the other figure where we are looking at the TSFP program, we'll estimate that the enrollment in the TSFP will be composed of more than half false positive, but then we have at least 38.9% of the cases are true MAM cases and a small percentage, that is the 5.8%, treated as MAM, of some cases treated as MAM. So looking at this, we are looking at it in terms of how the allocation of the different programs in terms of the eligibility in terms of admission. And we are looking at, if you look at the OTP, the AC program, almost half of them will be treated truly true SAM cases. But then again, we have another 49.9% of them being treated as SAM, MAM treated as SAM. And in this scenario, we have only 38.9% MAM treated as MAM, true MAM cases. And we have a small percentage in red color, indicating that these are SAM cases who will be treated as MAM. And we have a whopping 55.3% of false positives. And remember, in scenario 3, all these children are being enrolled into the program given the admission criteria. So looking at this, maybe we'll just conclude, given the experiences in Cox's Bazar. We'll go to the last slide. So despite the fact that we've raised our MOAC cutoff criteria, we've seen a number of challenges, the issues of false positive and the issues of misclassification. And a raised MOAC cutoff, referral cutoff is advisable, yes, where the concordance between the Z-score and, the weight for height and MOAC is poor, like we could see in the scenario 2 and 3 as already presented. So the MOAC cutoff needs to be carefully chosen to balance both case detection and inclusion of false positive. The expanded MOAC only admission criteria, like we've seen in the scenario 3, can be used elsewhere where the Z-score is impossible, the weight for height is impossible. That is in the context of COVID-19. And if there's any scope for us to use weight for height, it is highly recommended as a verification method, especially because the concordance between the weight for height and MOAC is poor. But in our case, when we adapted the issue of MOAC, we were trying to look at the COVID-19 issue and trying to at least minimize contact as much as possible, the issues of reducing the risk of transmission. And lastly, in terms of conclusion, we'll look at reflection, false positives that will be not admitted in the program, either in OTP or the TSFP. They need to be carefully managed according to the context, and they should be encouraged or supported by BSFP to reduce feelings of rejection. So it's just good to note that at least in Cox's Bazar, all children under 6 to 59 are already enrolled in the blanket supplementary feeding program. So at least we've been able to deal with feelings of rejection, but at least it was a learning for us. So with that, I want to end my presentation and over to Andy. Thank you.
Super, Caroline. Thank you so much for the experience in Cox's Bazar. I think we learn a lot. I think at the very minimum, you've explained very, very well some of the considerations that we need to be making around false positives and what does it mean, misclassification and whether they get treated or whether they get sent home and what the repercussions are of that, and that we need to be considering all this when we look at adapting our admission criteria to New York. Thank you for that, Caroline. Okay, next slide. We will go into our panel discussion in just a minute, but before we do, I want to say that we are behind, and I think that this discussion is really rich. I see a very active Q&A box with more than 40 questions there, and so I will say from now that we will go 15 minutes longer, so we will have our Q&A, we will have our panel discussion for the next 15 minutes or so, and then we'll go on to the Q&A before we wrap up. Okay, so with that, I would like to ask and invite our two panelists to join us. The first one, Ismail Kassim from South Sudan. And the second one, Naguib from Yemen. Naguib, I'm sorry, one second. And I will. So Naguib Abdulbaki from Yemen. If you two could join us and put on your videos, please, that would be much appreciated. And we will turn off our slides for the time that we will have our panel discussion. Great, welcome both. Before we start into our questions, Ismail, could you tilt your screen down just a little bit so we can see you a little bit better? And Naguib, hopefully you'll be able, yeah, there we go. Okay, but I don't see you, Ismail. There you are. Great, fantastic. Okay, so obviously we've heard some good. Yes, turn off the slides, please, Rita, so that we can just see our presenters while we're discussing. Thank you. Great. So from South Sudan and Yemen, we have two very different contexts, and I think contexts in which you guys have handled the situation differently. So first, what I would like to ask you both is to go through a little bit of how your country has adapted wasting case detection with the situation with COVID. Maybe I can go to you, Ismail, first for South Sudan, and then over to Naguib. You're on mute, Ismail. Great.
Yeah, thank you very much, colleagues. Good evening, good morning, wherever you are. As introduced earlier, my name is Ismail Kassim from South Sudan. So basically, I'll just take you through the context of South Sudan in terms of the case detection of wasting. So in South Sudan, during just after the period of the COVID, we have about over 1,000 nutrition sites within the country, and we have about 46 implementing partners that are supporting with the Ministry of Health that are operational in South Sudan. And so just before the detection of a COVID case in South Sudan, we developed a guideline for nutrition in the context of the COVID, which was in terms of looking at what adaptations that we need to take place. And these varied adaptations were from all sectors, from infant and young child feeding, from CMAM, from information gathering and knowledge, all that. So we developed that. But again, what happened is that we looked at our available data. And one thing that came up from the data from last year was that looking at our admissions, over about 80% of our children are usually admitted based on weight for height, based on MWAC, and 20% of them are admitted on weight for height. So this was something that we had in the background, that if we are now going to shift to the MWAC only, then we knew that we will at least lose about 20% of the children that we might not be able to detect. But what we did also is we looked at some of the situations that have been presented by my colleagues now. So we looked at expanding our MWAC of cutoff by to 135 millimeters, and what we realized was that we still missed about 55% of the children that had a Z-score less than -2. We looked at comparing both the weight for height and MWAC. So what came out was that we still missed 55% of the children that were still malnourished based on the weight for height. And the MWAC admission criteria also extending to 135, about 73% of the admissions were children that had MWAC between 125 and 135. We also realized if we do the MWAC admission criteria extension to 135, then there will be also issues on discharge, as those children that are admitted at less than 12.5 will have to be in the program until 135 millimeters. So that also had some implications in terms of resource. And so we look at all this and we realize we are going to triple our caseload in terms of the number of children that will be malnourished. And that had a huge impact in terms of our resource implications. And therefore we did not go and we did not proceed with that suggestion and stuck with the normal cutoffs of -1 to less than 125 for the mom and less than 115 for the son. So that's how we have adopted in our case for South Sudan. Over.
Great. Thank you so much, Ismail. It's really interesting, the analysis that you guys were able to do before making your decisions, and then understanding. So from what you said, you expected a 3 times, if you had increased the cutoff to 135, you'd have an increased caseload of about 3 times, partly because of the additional kids who would be found, plus the additional length of stay for those same kids.
Exactly.
For the kids that do go in.
Exactly.
Right, okay.
Yes. Yes.
Okay, very interesting to see the thought process that you went through. Over to you, Naguib, on the Yemen experience. So maybe you can tell us a little bit about the adaptations that you made.
Okay, thank you very much. And thank you very much to all colleagues and the organizers of this webinar. In Yemen, as in other countries, we follow the global recommendation to go with not using anymore the weight and height. So only MWAC was available for us. And for that, we used our data to assess our own cutoff points for this. For this reason, we used a large data set. It represents like 35 livelihood zones. The records are more than 18,000 children aged from 6 to 59. And then we use that data set. It gives us like possibilities to do, to include different variables in comparison, like age, sex, geographical, like even stunting. We assess what is the differences if we are using MWAC based and with these differences. In Yemen, just to say this, we start using combined in 2012 in one governorate, and 2017 we make it over all Yemen when we calculate the caseload calculation. So when we do our comparison now to get what is the cutoff point that we are going to use for MWAC, we compare the MWAC to the combined SAM and the combined MAM, and we started with SAM first to see what is the cutoff for SAM before we move to the demand. So with this large data set, we found that is the significant factors that can assess or can significantly affect the cutoff point is age and sex. But then it is not just the issue of having, you know, a better cutoff point, but also it is a logistic issue and do not need to make it complicated. Then we split the factor of gender and then focus on age. And then when we do focus on age, we did the analysis, we ran the analysis, we divided our children into 9 groups, 9 age groups, 6 months group, 6 months, 6 months, 6 months. And then we then start reading what is the increase in, like, for example, the true positive as well as the false positive. One, we are moved forwards to 1 millimeter, 1 millimeter, 1 millimeter of mark. And at the end, because it's, you know, it is not just a cutoff point, it's also a logistics issue, it is supplies, it is everything. In this case, we after we do this, we come to a consensus within the group that is, we should divide the children into 2 age groups. One is below 2 years and the other one is above 2 years. And for each age group, we have then cutoff point for SAM, and then we have it for MAP. So what we do, then our final discussion comes to that is for SAM, for example, the children under 2 years, we will keep it as it, 11.5, and it worked better, it's worked very well. And then above 2 years or 2 years and above, then we jump to 12.5 centimeters. So that is, gives the older children, you know, I mean, bigger cutoff point. So that is to catch as much as we can from the true positives to the program. And of course, as in the presentation, with just using MOAC only, whatever is the situation, whatever is the cutoff point, there is usually, we have missed children who are really true positive, but becomes false negative. Then those children become part of the MAM program. Becomes part of the MAM programs, and in the MAM programs, again, the same as the same used, but the new cutoff point for those under 2 becomes between above 11.5 to less than 12.5, and for the group from 2 to 5 becomes from above or equal to 12.5 to less than 13.5. And in that way, we could include, you know, more children. So, if we are looking to when we focus, then we go back to the SAM program, we found that is in total, about 57% of the true SAM cases is there. But again, because we increase the cutoff point, especially for the older group, then we got another 1% from those true negative becomes false positive. But those who missed in the SAM program become again treated in the MAM program, like 54% of the SAM now of the missed SAM now becomes, part of the MOM program. And the MOM program also catching more, and we found only supplies, that is, will be an issue to increase, not in the SAM part, but is at the MOM part. So this exercise actually in Yemen has been made first within the SAM group, initially by UNICEF, and then move together with our colleagues in WFP, and then we make a bigger circle to include the other partners in it, and then become wider and wider to have this. But only for some, this one, just to make it very clear, this is only for non-complicated cases, means that is for the OTB sites. If the child is some with this criteria and should be referred to the TFC or stabilization center. In this case, we do because right now the WHO still with all admission criteria as usual in the TFC. So because of this, we keep it only for those who have complicated and become some to remeasure using weight for height again before it is referred, because we are worried that is we refer the child to the TFC and travel long time, and then at the TFC they said, okay, no, you have not reached the admission criteria and back. So that is only for those very few children who are with complication to be measured for also weight for height before they refer to the TFC. Over.
Super, Naguib. A really interesting way of handling it, really considering those older kids and the fact that they might be missed if you used a lower MUAC cutoff, and so considering using your data, how to make sure not to miss out on those older kids that are wasted. Very interesting. I really would love to spend some more time asking more questions to both Ismail and Naguib, but I'm a little bit concerned about time, and I want to make sure that we also address some of your questions. So I will instead pass over now to our next session. Thank you so much, Naguib. Thank you so much, Ismail. I think there's super interesting demonstrations of different ways to handle the situation that we're in with COVID, and how you can look at your data to make some decisions, considering your supplies, considering admission and discharge criteria, and the implications those have on making decisions for programming. Okay. Now, Rita, can I ask you to put back on the presentation, and I'm going to hand over to Hassan now for the Q&A session. Thank you so much.
Thank you very much, Andy, for that, and thanks everybody for your presentations. I'm just going to go through some of the questions that have been posted so far in the chat box and the Q&A section. There are also some questions that were submitted prior to this webinar. Just a bit of a caveat before we start. We are likely not going to be able to answer all the questions that were posted. I mean, the chat box and the Q&A section has been quite active. So we will try and answer a few of them, but then we'll also provide a document that sort of addresses all the questions that have been posted, both the ones that are answered and the ones that will be answered later. Also to note that we have programmatic advisory technical groups that are in different working groups at the global level, at the GTAM, the Global Technical Assistance Mechanism, where some of these questions will be shared with those technical experts, and a more detailed guidance and feedback will be provided to all the colleagues. So I'll just start with some questions that were posted or sent a bit earlier prior to this webinar. And one of our colleagues is asking they would like to request if there is any further detailed information regarding how best they can conduct smart surveys during the COVID period, since we don't know how long, how exactly COVID and when COVID will come to an end. I will respond to this point. There is currently guidance that's being developed on how to conduct smart surveys during COVID. It should be released in the next few weeks, and hopefully that will provide a bit more detail to countries and partners on how to conduct surveys. In the meantime, the Nutrition Information Systems brief number 2 will be released today, and that will contain more information on guiding countries on how to use the existing data to conduct situational analysis, but also alternatives to how to use in case you're not able to conduct surveys. I will go to the next question, and this is a question to Jose Luis. And the colleague is asking, if case detection at household level does not require disinfection, then what about the health workers who come to the households? Do you think that these health workers can be possible carriers of the virus, and how can we mitigate these issues? Over to you, Jose Luis.
Oh, thank you very much. I've been trying to reply many of the questions on the chat, but there were too many questions. Thank you for that. So apologies if I missed anyone. Regarding this, I wanted to say that, well, it is not a request on the protocols to disinfect it if you are doing this at the household level, though if you have several children, this is a best practice. So always encourage to keep good things. And to answer the question specifically, yes, I mean, community health workers can be vectors and can transmit COVID. We have no doubt about this. Everyone can transmit COVID these days, so community health workers also. However, if you take infection prevention and control measures, PPE equipment, try to maintain social distancing, or for example, not entering the household. Many of these things can be done outside of the household in open spaces. Keep the anthropometric measurement tools disinfected, washing your hands often. The risk of community health workers transmitting COVID to a child in this situation is going to be very, very small. So I think we need to recognize that yes, there can be a risk, but this risk can be minimized hugely with the correct measurements. Thank you.
Thanks. Thank you very much, Jose Luis, for that. A follow-up question to you too, and one of our colleagues was asking, is there any studies that suggest increasing MUOC cutoff will increase the chance of capturing children with SAM using weight for height criteria?
Yes, there is several studies. I think I posted there a link to one study for Doctors Without Borders from a few years ago on Burkina Faso specifically. It was a pilot study, but there has been other articles published, and I'm sure if whoever asked this question reached to the RRT, the rapid response teams later, more examples can be shared. But yes, there is more studies. And of course, the more you increase the cutoff for MUOC, the bigger it is, the more weight for high children you are going to include. There will be a moment that if you increase it, I don't know, big enough, if that MUOC cutoff is big enough, it will increase all weight for high children. Also, the problem is, as Alexa was saying, that we will start introducing a lot of false positives because there will be many children who are also false positives. So the cutoff is to find that balance on identifying the most cases possible without introducing many false positives. Thank you.
Thank you very much for that. A lot of the colleagues were also asking about or curious to know about the 3D scanning technology that was presented. And they wanted to know a bit more information on where it is, how far it has gone in terms of development, when they should expect it to apply it?
Well, I know I'm not myself involved in this kind of approaches, so I cannot give you exact date. Maybe someone else here in this call can say more specific dates and details. I know a little bit from what I have read. I know a few organizations are trying to implement different approaches. The one I know most is that one called SAM, Photo Diagnosis by Action Against Hunger. It started years ago now, like 2, 3, 4 years ago. And they wanted to have results even 2, 3 years ago, but it's proving more difficult than we expected. I think there is a lot of science behind it, a lot of IT and coding and developing of apps and software. But the idea is, yes, that we will be able with a mobile phone, taking a picture in some way, but taking a picture of the child, that the computer will analyze that picture, try to create a map, a 3D representation. We won't see that 3D representation, but we'll create a 3D representation of the child, and we'll calculate some anthropometric parameters automatically. I think we are not there yet. I don't know if someone else have better details. I don't think we should consider them for COVID at the moment as an alternative for case detection in COVID time, but we include it there because clearly COVID is going to give these pilots a push, and hopefully we may have these apps available soon. But we've been saying this for a few years now.
Yes, thank you very much for that. Just to add, I can see that Joel Kunkel has posted some links on the chat box for colleagues. And also, in addition to SAM Photo, we have other technologies that we've been working on. One being Child Growth Monitor. It's an initiative by Welthungerhilfe. And I can ask maybe Marcus to just to put a link on the chat box if possible, for people to know more about the technology. This is a bit more advanced in terms of progress. They have been testing the application in India for some time now, and they're looking to maybe have something out probably by the end of the year if everything goes well. It's very exciting to hear that. So moving on to a bit more questions to Alexa. The colleague wanted to know what determines whether MIOC predicts more SAM children or not. Is this just based on population parameters, or is there some rationale for why context has different overlaps?
So that is a very complex question, and the long answer would require a long conversation. The short answer is we don't always know exactly why they're different in different contexts. There's different working theories about certain indicators detecting more male children or female children or tall children or short children. It's quite complex. But it's just to say that the reason MIOC might capture more SAM children in a given context is likely because the weight for height and the MIOC are more aligned. But if we're seeing them be less aligned, those two indicators, then likely your MIOC is going to detect a smaller number of SAM cases for that population. Over.
Thank you very much, Alexa. Then a follow-up question from one of the colleagues was, could you make any comment on the characteristics of the two countries, the two anonymous countries, context in terms of nutrition situation, programming context, etc.?
I don't think I'm
too much information.
I don't think I can give any information, actually. It's just, the only other information I can say from a analysis side is both countries were based off of 7 different, each was based off of 9 different smart surveys from different parts of the country. So we felt that it was a nice sampling of children from those 2 countries so we could understand the relationship, but I can't speak to the programming, I'm sorry.
Right. And maybe just to add to that, I think the intent of presenting those 2 countries was to reflect the 2 extremities, and really drive home the point that context has a big factor to play when it comes to the concordance between weight for height and MIOC. So context is a very important consideration to make these kind of decisions. A few questions were asked to a colleague in Cox's Bazar, Caroline, and I'll just sample a few. So one of our colleagues was asking, how did you handle the reaction of caregivers who were referred with 13.5 but were not admitted since admission was at 12.0? Did this discourage subsequent referrals?
Okay. Thank you, Ali. Okay, maybe to respond to that, like I've already responded, we mentioned that all the cases are admitted to the BSFP program. So we were able to deal with the rejection of cases. Those who are falling between less than 13.5 to less of the admission criteria, they'll be admitted in the BSFP program.
Great, thank you very much. And then the follow-up question to you, Caroline. One of our colleagues is asking, was the rush fund size for RTFs? Did it remain the same for some children admitted according to the adapted admission criteria in Cox's Bazar in the context of COVID?
Okay, once we adapted the criteria, we also changed the number of sachets given to the children based on the age category. So the children 6 to 23 months are given 2 sachets per day for 14-day period, and children who are older, 24 to 59 months, are given 3 sachets of RTF.
Great. Thank you very much for that. And maybe a final question to you, Caroline. Were there any misclassification of cases, and what contributed to them? Was it due to human error? You're on mute, Caroline.
Sorry. Alexa will help me to respond to this, but misclassification happened in especially scenario 3, where we had adjusted the MWAC admission details. Like if you look at the OTP, the admission has gone up to 12.0 centimeters. Basically, on a normal situation, we have our admission as up to 11.5. So you can imagine that we may end up with a SAM case, a MAM case being treated as a SAM case. It is basically based on the admission criteria, and that's why we have the misclassification. It is due to our admission criteria into the different programs. Alexa, could you add anything? Thank you.
Yeah, that was beautifully said. Just to add that anytime we're going to extend MUAC thresholds above WHO threshold, so above 125, so if it goes from 125 to 135, in terms of true cases, if you don't have a way of verifying those cases, let's say also with weight for height, you may have a child whose MUAC is, let's say 129, but we're not doing a secondary verification. We're going to enroll them in TSFP, for example. But maybe if we could have verified them by weight for height, we would find that they also were not MAM by weight for height. So it's just the nature of when you raise a threshold above WHO thresholds, you will have a certain proportion of children that they no longer fall nicely in those categories because we're not able to verify their real status. I hope that helps.
Thank you very much, Alexa. And then maybe a final question that's more open to the panelists. What is the discharge criteria for MUAC expanded criteria of approaches?
Can you repeat the question?
What is the discharge criteria? What is the discharge criteria for MUAC expanded criteria approaches?
I think most people, I think Andy might join now and said something that different programs may be using different discharge criteria, but from the ones I know, I think they are using the same as admission criteria. And I think in MSF, we are using a discharge criteria in some places of more than 1, 2, 4, and it's working quite well for us. Thank you.
Great, thank you. And I think this is something that we can definitely provide more information and more detailed answer to once we share it with also the technical experts in the different working groups. There is a question that was asked by one of our colleagues in relation to combined GAM, and I'll address this to Bijoy, where they're asking, I mean, a colleague was asking, so do we consider combined GAM as the new sort of indicator for caseload calculation? Is that the recommendation?
Before you answer, Bijoy,
okay.
excuse me, just to say we are going to need to start wrapping up, so if this can be our last question, that would be great. Thank you.
Okay, thanks, Hassan, and thanks for the question. To respond on that question about whether we can use combined GAM as a new indicator for caseload, well, we have some example, as my colleague Najib shared from Yemen. They use combined GAM, and I also know in Afghanistan they have been using combined GAM for caseload calculation because of the poor concordance between weight for height and MWAC. So they want to make sure, because also it's also linked with their programming in Afghanistan and in Yemen also. Before COVID, the programming approach was the admission criteria and treatment criteria was using both weight for height and MWAC. So they wanted to make sure that they capture all the children in this two criteria. So they have used this combined GAM, we call it CGAM, in their annual HNO and HRP process. So this can be used in a brief, depending on the programming nature, if they're using both, and if the context allow, if they have adequate resource, this can be used, yes.
Thank you very much, Vijay, for that. So I'm gonna stop here just because of time, but I'm really happy that we have a lot of very interesting questions. Please don't be disheartened if your question was not addressed here. We'll make sure that we provide detailed answers to all these questions and share with you together with the webinar recordings and the presentations. Thank you very much. Over to you, Andy.
Wonderful. Thank you for that, Hassan. Thank you for all the panelists, Alexa, Jose Luis, Caroline, Bijoy, Negi, Ismail. Super interesting, and I wish we had much longer. With that, we do have to go on because I think everyone has lots of other things to do as well. So what I will say in regard to the questions, as Hassan has mentioned, we will attempt to answer all those questions in reply when we send out the presentation and the webinar recording. For those questions that cannot be answered, we will make sure that they get passed along to the teams. They're called program adaptation teams that are answering questions that come in. So if it's something that is unanswerable, it will go there and be considered to try to see how it can be answered. So please, that's part of the GTAM, the Global Technical Assistance Mechanism for Nutrition. Okay. With that, I want to mention that support is available to do this analysis if you would like, either through the Tech RRT and the SMART team. Please do reach out using those two email addresses at the bottom, whichever one you use is fine, and we all can help you using your existing assessment data to inform your programming to help you go through that analysis. And so please don't feel shy, and please do reach out, and we're happy to help in any way we can. Next slide, please. Okay, then for more general support, I think a lot of you already know about the Tech RRT, you know about the SMART projects, you know about the GTAM, possibly or possibly not. More information will be coming soon, but there's lots of support available through these mechanisms. If you want remote or in-country technical support, the Tech RRT, the SMART team, and other organizations through the Global Technical Assistance Mechanism can support. If you want to hire a consultant directly, there are a series of 5 different consultant rosters that are part of the GTAM, and they are accessible on the GTAM website by putting in a request. We also can provide, there is a possibility to answer quick questions. That's mostly through the GNC Help Desk. In particular, there are several help desk staff that can answer questions depending on the technical area of the request. In any of these cases, if you reach out through that email address, that website address, gtamnutritioncluster.net, you just click on request support and we can help you from there. Soon we'll likely have a webinar to tell you more about it. But with that, I'm not sure if there's another slide. If we can go on to the next slide, please. Should be one more. Great. At the end, when you disconnect from the webinar, you will be asked to fill out an evaluation. Please do take time to do it. It will take you less than 10 minutes, hopefully more around 5, to give us some feedback on the webinar, also to let us know if you have any ideas on things that you want us to bring you webinars on. And other than that, you can reach us through our websites or through Twitter. Whatever questions you do have, we will make sure that we pass them along to others if it's more appropriate for them. I want to thank everyone who has participated today, starting with the participants and attendees. We've had a great turnout of more than 300. And I want to thank all of our presenters and panelists, as well as our translators and people from behind the scenes. Wishing you all a great afternoon, evening, rest of your day, depending what time it is, and that we see you on some other webinars. We have several of other webinars this week, and feel free to drop us a line if you haven't heard about them and would like to have more information. Thanks a lot and take care.
Thank you. Bye.
Thank you, everybody.
Thank you, everybody.
Everybody. Thank you so much.
Thank you.
Bye-bye.
Bye.
Oh, Hassan, we are leaving?
Yes, we can leave.
Okay. Sawa.
Asante sana.
Asante pia. Long time.
Yeah, siku njema.
Okay, asante.
Yeah.